Hi, welcome to today's episode of OBGYN Nuggets. This is a segment with Conceptual OBG wherein we discuss tiny but significant topics in obstetrics and gynecology. And today is what I call as the hepatic conundrum. Often we say that two significant high risk disorders in obstetrics, that is the HELLP syndrome and acute fatty liver of pregnancy, are like cousins to each other. But not often do we know what is the difference, what is the clinical differentiating factor between both of them. Eventually, it all boils down to what we perceive retrospectively. But is there a way for us to know antenatally and immediately which is the disorder that is intervening and what is the reason this major difference comes in? So, here's a discussion on that. So, HELP syndrome, as we all know, is a complication of severe preeclampsia that occurs. In it, there are three components. One is the hemolytic component, the other is elevated liver enzymes, and finally, there are low platelet count, that is thrombocytopenia, that intervenes. Now, because of the hypertension and thrombocytopenia, there is periportal hemorrhage in the liver. So, basically, around the portal system in the liver, there is going to be hemorrhage. When this hemorrhage accumulates, it leads to formation of a hematoma inside the liver. This hematoma ends up stretching the liver's capsule, which leads to eventually which leads to right hypochondriac pain that the patient often complains of. It is, if you remember, a classical complaint that we ask in pre-monitor symptoms along with diplopia, altered sensorium, epigastric pain and low right hypochondriac pain is one of the significant components of pre-monitor symptoms. After this, there is hepatocellular necrosis. Basically, the hepatic cells, the hepatocytes, just start dying. And whenever they necrose, they let out an enzyme that is called as serum transaminases. So, serum transaminases or SGOT and SGPT are released into the serum, and hence there is elevated liver enzymes that is seen in HELP syndrome. Whereas in acute fatty liver of pregnancy, because of deranged, damaged free fatty acid oxidation, there is increased deposition of fat throughout the liver. There is microvesicular steatosis, classically as they say on histopathological examination, which means that there is deposition of small globules of fat across the liver. This leads to complete liver dysfunction. And by dysfunction, I mean the basic functions of the liver are deranged. What are the four major functions? One is the synthetic function, that is the production. There is production of coagulation factors as well as production of proteins, especially the albumin that is deranged. So, when the coagulation factors are not being produced, there is going to be a state of DIC that manifests in these patients. This DIC is also compounded by the endothelial dysfunction that happens in acute fatty liver pregnancy. Because of less albumin and proteins, there is going to be low oncotic pressure and there is going to be transudation of fluid into third space, leading to hemoconcentration. This hemoconcentration eventually leads to increased viscosity of blood and deranged uteroplacental perfusion and eventual fetal death. There is also loss of the metabolic function. So metabolism, liver metabolizes ammonia by urea cycle. This ammonia starts increasing in the body. There is hyperammonemia, and this hyperammonemia leads to encephalopathy that manifests. Often these patients come to us with the presence of an altered sensorium in a confused state. That is because of this encephalopathy, because of increased NH3 levels, that is ammonia levels. The next function is the storage function. It is a store of multiple vitamins and glycogen. This function is deranged, and hence the glucose levels in the serum start going down, and there is hypoglycemia in these patients that manifest. It is very classical of AFLP. And finally, the excretion function of the liver is deranged. There is increase in the serum bilirubin because it is not being excreted anymore by the liver, and hence there is icterus and jaundice. So the basic difference in both of them is there is hepatic dysfunction in acute fatty liver of pregnancy, whereas there is no hepatic dysfunction. The liver is still functioning well. The synthesis function is maintained. The DIC in HELP syndrome is never going to manifest because of liver dysfunction. There is no metabolic disorder, hence there is no encephalopathy. There the patient might develop post-ictal confusion, but that will be because of the eclampsia that comes in HELP syndrome and not because of the liver that is causing encephalopathy. There is no hypoglycemia, which is a classical feature in AFLP and not in HELP syndrome. And also the bilirubin that is increasing is not as increased in HELP syndrome as much as it is increased in acute fatty liver of pregnancy. And hence, these two cousins are very much same, but still significantly different. Thank you.